My name is Ben Buchanan, and I want to talk about measurement-based care and the future, or what I think is the future of psychology. But to look ahead, I also want to look to history to see what we can learn. For disclosure of interest, I am the CEO and founder of NervoPsych. I know lots of people at this conference use NervoPsych, and I'm also on the a member of the Better Access Review, which is currently funded by the Department of Health, to see how effective Better Access is, and we're doing a pilot study on integrating measurement-based care principles into Better Access. So before I talk about therapy, I want to talk about what we can learn from other professions. And what do you think this person does? Well, it's pretty obvious because they've got a stethoscope. And when you Google doctor, 29 out of the 30 images have a stethoscope. It's almost like they're defined by the tool of inquiry and measurement that they use. And here's a builder. I want you to imagine that you were doing a reno on your house and you invited a few builders around to give you quotes. And one builder came around and he said, "Look, I'm very experienced. I don't use tape measures because I just use my judgment." That person would not be doing your renovation. You want a builder to reference standardized measurements. And same with a bricklayer. A bricklayer sees that they're on track constantly by a guide rope so they can adjust what they're doing. Pilots look out the window. They use the feel of the aeroplane, but they also have a huge dashboard to measure their altitude, their wind speed. And I think that psychologists can learn a lot from these other professions and continue to do what we're doing, which is taking a highly complicated, individualized, sometimes chaotic experience of a client, and then yarn that into something that makes sense. And I think we can continue to do that using our clinical judgment. But I'd also like to suggest that we could have measurements in addition to that. So I want to talk about thermometers and the history of thermometers in medicine. Hippocrates knew that temperature was somehow important to health. He didn't quite know how at 400 BC, but he taught his medical students to lay their hand on the forehead. And a couple of thousand years later, or 1,000 years later, there was a group of fringe doctors that started to use this new-fangled thermometer, or thermometer. And these thermometers took 20 minutes. It was painful for the patient and the doctor, and it was unreliable. And it wasn't well accepted. Most practitioners preferred to still lay the hand onto the forehead of the client. And then in 1867, a convenient thermometer was introduced that took only 5 minutes, and just a year later, some compelling research was published that firstly showed that if you graph temperature over time, you could predict the course of illness, and by graphing that temperature over time with this reliable measure, it could inform treatment. And then skepticism reduced gradually because doctors still liked putting their hand on the forehead because they rightly saw that there was something special about putting their hand on the forehead of a patient. Well, it not only could measure temperature, sort of, but also clamminess. And they picked up on this other thing, that there was a special bond between a doctor and a patient when they were laying the hand. But eventually skepticism reduced because it just became easier to just, instead of laying the hand, just like shoot them in with infrared thermometers. So that is the history of thermometry. And it took 1,000 years between some basic knowledge to really widespread use in clinical practice. And there was some barriers to it being used, and firstly there was a technological barrier, and there was an accuracy barrier, and also the concept of fever wasn't defined. No one knew what a normal temperature was, what a fever was, and so it took high quality data graphing fever over time on a plot, and there was a reliance on clinical judgment. And I want to read this quote from a book called From Patient Data to Medical Knowledge, and it says, "A doctor who has devoted years of education and training to acquiring and refining a particular skill will inevitably be reluctant to accept new developments that seem to make all that effort redundant." And so this translation of basic knowledge into research knowledge into widespread use can take centuries. So let's look at measurement in psychotherapy. I'm going to see if I can draw a parallel here. I'm going to skip lots of bits, but I'm going to start with the MMPI in 1937, which was the first objective sort of psychometric measurement, and really, for the time, relatively robust psychometrically. But it wasn't that widely implemented because psychotherapy was still dominated by psychodynamic ideas where expert judgment, interpretation, which is the psychotherapy equivalent to laying the hand on the forehead, was predominant. And then Lambert in 2005 released a huge paper showing that if you gave objective measurements and plotted those measurements over time, you could use them to inform clinical practice, and you got better outcomes as a result. And then computers came along. Instead of the MMPI that was painful to score, we could do it on computers really easily. And then in 2015, measurement-based care was defined, which I'll talk a little bit about that definition shortly. And I hope by the end of my talk, you will think that in 2025, measurement-based care will be widespread because of new technology and the fact that augmenting our clinical judgment with technology gets better outcomes. So I said that measurement-based care was defined in 2015. Really, there's been concepts like this for a long time. In 1988, routine outcome monitoring was introduced. Progress monitoring, which was initially a term that was used in the education system to look at the progress of students, was popularised in 2013 in psychotherapy. And then feedback-informed treatment and step care are they're all synonyms for measurement-based care. There's slight differences. But measurement-based care is defined as the systematic use of symptom monitoring scales and the use of those results to drive decision-making at the level of the individual patient. And so I'd like to contrast measurement-based care with what normal care typically looks like. Normal care, there's usually an assessment, and then, which is like a clinical interview, we say, how are you going? We lay our hand on their forehead metaphorically. And then we do a formulation or a diagnosis using the DSM or however we formulate our client. It doesn't have to be a diagnosis at all. And then we do treatment, and then we finish up. And we try and finish when we think that the treatment has been a success. But my challenge to you is, how do you know when treatment has been a success? So one thing we could do is give a self-report measure at the start and at the end and see the difference. Has there been a change? So for me, I use the DAS. Has there been a change in symptoms? But for you, it might not be a symptom rating scale. It might be a measure of mindfulness or living consistently with one's values or an eating disorder scale or PTSD scale. But looking at treatment outcomes is not the only ingredient that is needed for measurement-based care. It's just the first ingredient. The next step is progress monitoring, which is looking at the progress and graphing treatment over time during the course of treatment. And that way you get early feedback. Is treatment working? Are they getting worse? Could I be doing something differently? And then finally, the final ingredient for measurement-based care is using measurement tools to aid formulation at the outset, to make recommendations on what treatment is going to be worth it. Are they going to respond to treatment? So that's what measurement-based care is, and I'd now like to show you how I do it in my practice, in my private practice. Here are some results of a patient of mine. And this is using the DAS, and the y-axis is a percentile rank. And anything above that dotted line is considered to be clinically significant, and anything below is okay. The way I do this in session one is I pass an iPad to the client and I say, "You told me a lot about how you're going. I'm wondering if you can spend a minute filling in this questionnaire so we can get a bit of an objective measure about how you are." This client did that, passed it back to me, I showed him this graph, and I said, "This is showing you're really depressed." And he started to cry, and he said, It's real, I'm not making it up, it's not just all in my head." He found this incredibly validating. I turned something invisible and intangible into something real and measurable. And so I saw this young man for a year, and he was depressed for a while, and then he got better. And in August of 2019, we reflected back and we said, all right, well, it seems that you're in a really good place now. It seems like you're well. It might be time to discharge you. What do you think made a difference? Why do you think you're now better? And of course, what I wanted him to say is, "Oh, Ben, it's because you're an amazing therapist." But he didn't. He said, "I got a girlfriend." And I was a bit jealous. And so I looked back at my notes, and he looked at his calendar, and we said, "Okay, well, when did you get a girlfriend?" And we put it on this graph, and we said, "Okay, you got a girlfriend right there." And I was like, "But you were still depressed for quite some time. Was there anything else?" And we discovered that at the start of 2019, he decided to go back and study postgrad teaching. And for him, this was a real expression of him living consistently with his values. It was an expression of him breaking free from what his parents wanted him to do, taking a risk, an anxiety-provoking risk at first, as you can see in January of 2019, and then enrolling, going back to university and studying. And so for this client, the key takeaway from this was he's got to live consistently with his values and be feeling like he's making progress in his life in order to stay well. And so part of his discharge plan was that if he noticed that he was just on autopilot, that he was just going through the motions, that he felt like he wasn't living consistently with the things that mattered to him, that was a risk factor for him getting worse. Here's another client. Now this is the DAS as well, but instead of looking at the 3 symptom scales, I've just broken it down into a general level, a general distress measure, again using percentile ranks. And there are 3 episodes of care here. The first episode of care was CBT. And so he came in very distressed. I did CBT and it fixed him, and I was like, "I'm amazing." And then a year later, he came back. And so I thought, well, I'm amazing. He responded to CBT, I'll do that again. But it didn't work. And so I did more CBT and more CBT and more CBT, but it still didn't work. And so I thought, all right, well, I've got to be doing something different. He's not getting better. And so I referred him into a group focused on compassion and mindfulness, and he got better. And it was a pretty dramatic change, and we were able to see this extremely clearly, and I'm not sure I would have seen it with that much clarity. Firstly, to refer him into that group, to know that what we were doing wasn't working, and then also to provide that clinician with feedback saying, look at this graph, you just did amazing work, was pretty powerful and encouraging for that clinician as well. It's also great for just including these graphs on GP letters. I think GPs like it, and also, I've got a graph there showing that, when someone started medication, they really responded to that. I think GPs appreciate getting that feedback. And also when a client is considering coming off medication, looking back at the graph and saying, okay, well, when did you start and finish it? Let's test this hypothesis, talk to your GP, come off it, I'll continue to give you these assessments so that it can be more rigorous. Because us human beings are terrible at remembering how we were yesterday, let alone last month or last year. The computers can do that perfectly. So I'll show you how I do measurement-based care, but I want to talk about why it might be a good idea and talk about the benefits of it for clients first. Firstly, I think they like it. Honestly, I just think they like it. It makes things tangible. It also improves treatment response. You can augment standardized measures into any way of doing therapy. It doesn't matter what school you belong to, what therapeutic approach you use. There's data showing that augmenting it with these principles of collecting data and giving feedback to a client can improve the effect size. And there's also some benefits for the psychologist too. It reduces dropout. It means that we feel like we're engaging the client better. It helps to create shared conceptualizations with the client, work collaboratively. But also I want to talk about the benefit for a psychologist, because I think that unless something's super easy and you can see the benefit for not only your clients but also for you, it'll be harder to implement. So this is some of the reasons I like doing it, is that I think it makes my life easier. I don't think I would have been able to have some of those clinical insights without that data. And I think also that like a pilot flying a plane, they can do it off feel, their intuition, their expert judgment, or they can look at their dashboard and they can see some objective measurements. And any pilot will say that they couldn't fly safely without it. And that's how I feel about therapy these days as well. Our job is really hard. And we work hard. And sometimes when we're working, it feels like we're just seeing client after client after client. We don't actually zoom out and know if what we're doing is making a difference. And so one of the benefits of collecting this data is that you can zoom out and have a look. Is all that hard work, is all that training that you've got, is all of that expertise making a difference to the clients? Which is why we got into this game in the first place. And so I want to briefly present my data from private practice from 2014 to 2022 with 300 clients using the DAS. And so this is the distribution of results on the DAS at the first session and at the last session. And at the first session, the average score was 32. And at the last session, the average score was 19, and that's an effect size of 1.1. And this is another way of representing the same data. You can see that for clients that saw me for between 2 and 5 weeks, their average DAS was about 31 when they started, and it reduced to about 20 when they ended. People that stayed a little bit longer got a little bit more benefit. So the more therapy you get, the better the results. The higher the dose, the more the response. And people that stay with me for 11 plus weeks, they stayed because they were more distressed to begin with. And they experienced the most benefit of the lot. And so this data will be contributed to that better access review that's currently underway, and I hope will provide some powerful advocacy for the continuation of 20 sessions per year. So my hope is, in decades to come, when people Google psychologist, they won't just find that classic picture of 2 couches with 2 people, with someone with a clipboard, which is the classic image of a psychologist. I hope it will also include some reference to the methods of measurement we use or the tools of insight that we have into our clients. It doesn't just rely on us metaphorically laying our hand on the client's forehead. I'd love to hear questions or feedback. Thank you.
I gave the questionnaire to DAS to one of my clients the other day, and she said, good. And I said, why did you say good? And she said, it reassures me that we're here for a reason. And of course, which really galvanised her motivation. I'm really interested in those last couple of graphs. How did you get those? Because I'd be intrigued to do those for myself.
What an amazing question. So NovoPsych is currently developing this, and so in the NovoPsych platform there will be a new button that you will see appear in a few months' time that will give you access to all those metrics.
Terrific, thank you.
Hi, just with your graphs of your individual clients, it looked like you were administering the DAS monthly, is that correct?
I tend to administer every second session or so, but I must admit I tend to not be very available for my clients, available enough, and so there are sometimes gaps between our sessions.
So I'm just wondering your thoughts, every second session, every session, as Alan spoke to, what are your thoughts about that?
I think it's a really difficult one. So the pro of every session is that you get immediate feedback. I think the way Aaron does it is he does it in the waiting room, which makes doing it every session easier. I like to do it in the therapy room, and I do that for a couple of reasons. Firstly, because it sometimes gives me a minute just to. I do it usually in the middle of a session or sort of near the end, but it gives me a minute just to look back at my notes while they're doing it, to sort of think, all right, well, where are they up to in their plan? Look back at my notes about that story they told me last time that was relevant or whatever. So I do it in the therapy session, but doing it every session in the therapy session feels like a little bit much to me. But I certainly wouldn't be doing it any less than every second. And because the difficulty is that if you do it less than that, you're not getting the feedback fast enough. And also people drop out and then you don't have data to know how they actually went at the last session. So I think somewhere between every session and every second session.
I'm just curious what you said towards the end there about making the distinction in the future where we don't picture the couches but measurement-based care. How do you envision that being delivered to the public so it becomes a thing they have consistently think about when they think of psychology?
Yeah, so I think that when we go to parties and people say, oh, you're a psychologist, can you read my mind? My mission is to say, well, no, I can't read your mind, but my technology can. And I think that we can do that in many ways. At the moment, we rely on self-report, right? Which is okay, but it's sort of, to draw the analogy between a thermometer or temperature, imagine if doctors were saying, well, how hot do you feel? That wouldn't be accurate enough. And I think one of the problems we've got in psychometrics right now is we're using self-report. I think we've got to get past that, and I think that there are some really interesting techniques and methods that we can get past self-report, but I think that they're some years away and certainly something I'm working on.